time it is. Marvin Devine, Hoover, Axel, and you know how we do.
Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, Axel, and Hoover, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof.
You already know what happens when we link up. Let's go.
Yeah, I got the
Good morning, good afternoon, good evening, wherever you're watching. Welcome to another edition of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Joining me in a few seconds is our other host, Brother Moses Kennedy, also known as the Kidney Ambassador, broadcasting from Nairobi, Kenya. Today, we have an exciting but informative show for you. Please share this live, share this broadcast, and tell anyone you know right now that's about to get access surgery for dialysis to come tune in or watch the after show. Now, access surgery, right, for dialysis involves creating a vascular access point that allows for the removal and return of blood during dialysis treatment. Now, there are three main accesses, right? Three main. Yeah, and the types of access surgery for dialysis involves creating a arterial venous fistula or implanting an arterial venous graft or the placement of a hemodialysis catheter. So without further ado, let me bring on half of our other hosts, and we're going to talk about access surgery and Brother Moses access surgery. So let me give Brother Moses the VIP intro. Moses. Good
Oh,
evening.
yes, Brother Steve. How are you?
All right, how you doing?
I'm doing great.
How you feeling? Because I know you had access surgery last week. Tell us
Uh,
about that.
a little bit tired. A little bit tired, of course. I think my HB is low, but I'm well and good. So
What
it's
you
been
think
a
you saw?
tedious.
You think what is low?
I guess my HB is low.
What's that? For people who don't know.
Hemoglobin level
So your
is
blood
low.
count, you believe
Yeah,
is low.
I believe because I'm getting tired. Although
Mm,
there is getting tired of daily basis, but then there could be some extra loss of energy that indicate hemoglobin is low.
okay. Do
Yeah.
you receive any medicine to increase your hemoglobin?
Yes, I've been doing that. The only thing I haven't checked, I'm only suspecting, right?
Or you're only suspecting, but you don't know for sure if it's low.
Yeah.
So what day, Brother Moses, did you get your access surgery?
Oh, yes. It's been really a long and tedious journey. You remember, as I've always mentioned, Kenyatta National Hospital being a referral hospital, and more so in East Africa. So you realize there are several cases on each medicinal department. Now, to get an access in Kenya is no joke if you don't have the cash money. But then when you get a referral to hospital, it can be subsidized in a way. In Kenyatta National Hospital, it can take several weeks if you don't plan properly, you know. And then when you want to plan it the better way, you need to get your own consultant, thoracic and vascular surgeon. Then you book an appointment, go see him, and then thereafter, you get to know now way forward. Yeah. So when appointment is done, the patient is prepared and given a date based on bed capacity. And you know, bed capacity in Kenyatta is sometimes overwhelmed because it is being a referral hospital. Now, you who is stable, who only comes for a graft, but has still a catheter, sometimes you'd be sent back home to give space for emergency until when the bed space is available. So basically, admission and preparation for your surgery can be delayed based on those surgeries. But then now, when my time came, I was just taken to theater very early in the morning. It was done. And then everything went on well. You know, I had the first one, then it failed. Every fistula failed. Then we had another one, which is now AV graft that is doing quite well. Now, I believe it has still that thrill. As you can see from my arm, it is still fresh dressed, and quite positive about it, Steve. Back to you.
So, Brother Moses, when you had let's go back to your first surgery where you got a arterial venous fistula. And what that is, an AV fistula is created by surgically connecting an artery and a vein, usually in the arm. Now, this allows for increased blood flow and a stronger vein, making it an ideal access point for dialysis treatment. Now, when you got that first surgery of the AV fistula, when did they find out that it wasn't working?
After 5 days, I went back for a routine checkup clinic. Then it was tested using a stethoscope. And then I was told by my surgeon that this thing is not maturing up. It is dead. So let's plan for this. Then we planned, and that is how it took place.
So, Brother Moses, I know here in the United States, when kidney warrior is referred to an surgeon to get access surgery, they do what's called vein mapping, where they look at the veins to see are the veins large enough for this to happen, the size of the veins, and which arm would be the best arm. Usually they try to go with the non-dominant arm. Now, did you have a vein mapping done to look at your veins before actually getting the AV fistula surgery?
Well, you know, other tests and such like vein mapping comes with a cost. And then, you know, our doctors in Kenya, they really understand patient, that most of them are unable to afford other cost. Now, mapping was just done by physical eye, which is normally the case because those surgeons over there are sure. And then later on, it will mean that I'll have to cough some money. You get it, Brother Steve, to get that mapping and then to get that fistula done. Now, if you had the money, that is the right protocol, that you would go for mapping first and be sure. But then you want a fistula, you want a graft. What do? And you have the money for other services. So you can escape one. That is the mode of survival, Brother Steve. So basically, no, they never did a mapping with an ultrasound. Okay. It was just checked. It was just checked by a physical eye, where the veins were tied to increase more pressure on the veins so that they can see. Then that, in fact, that is the mode they use, because they also want to reduce the burden to the patient. Yep.
So, in actuality, pretty much patients are taking a risk, almost a gamble, when they get the fistula surgery if they don't have the money for vein mapping, because the veins may work or they may not work. You really don't know until after the surgery.
Oh, yes. There are those who get the money and do the mapping. And then after the mapping, still it fails. It is 50-50, as you know, Steve.
Well,
it's always 50-50.
Yeah, but
yeah.
Normally doing the mapping, it gets determined if the veins are small, and if they are, then maybe go the other route and do a graft. So basically, if you could have got the mapping done, it could have saved you trouble by saying, "Oh, the veins are small. Let's go ahead and do a graft," instead of cutting you to do a fistula, and now you had to do a graft. Okay, yeah, this is, I I wish that they had the same insurance and access for kidney warriors over in East Africa as they do here in the United States. Because now, you know, you had to pay for one surgery. Now, on top of that, you got to pay a second surgery.
Oh yes, but then, Brother Steve, you know, on the ground here in Kenya, you know, the setup is maybe completely from developed countries, namely US, UK, Australia, name it. But then I also believe that in a way they are waiving the cost to the patient. Why? You have an admission, you have paid some money. If there is, if for those who do not, let me speak for those who do not have any insurance, right? You go there, then you want to be taken round that you do this and that and that. But then if you have the money, in fact, for the first time, doctors will evaluate your financial capability. How are you going to pay this? What about the expenses? So the doctor understands you well and knows how to best try to assist you. That is why sometimes it happens that way. So they are just trying to assist patient in a more I would say they make they make it tailor-made, yeah, so that it suits that particular patient. Yes, but they know you will be informed that this is all what you need, but we can also have this option after you understanding. Then you decide which one you want. So it's about helping warriors.
Got you. So what you end up getting after your fistula didn't work was an arterial venous graft.
Yes, so that is when I had gone ahead and planned with my vascular surgeon. Then we scheduled, and then it was done. So,
All right.
Brother Steve, on that day, it was thrilling so nicely.
All right. Before you move on, let me just explain what an AV graft is. An AV graft involves using a synthetic tube to connect an artery and vein. This is typically used when a patient's blood vessels are not suitable for creating an arterial venous fistula. Now, Brother Moses, you had mentioned to me that your surgeon directed you to buy your graft on the black market. Now, explain to our guests the black market and how you was able to attain what's called here in the United States durable medical equipment, which most of the time these accesses like a graft is in a sterile package. It's sterile because it's implanted under your skin.
Yeah, it
You
is.
can hear some feedback.
Well, it is not being bought in black market. It is being bought on a genuine company retailer. So, like the government tries to subsidize the burden on patients by patient themselves buying the graft, maybe buying the catheter. They are all bought. You can buy it, and then it is not in the black market. It is on a private listed companies that you just choose one and buy. So it is well packed. You just buy and take it. You just buy, or your surgeon can go and buy it for you if he has the time. So that is how it is done, including catheters, not only graft, including catheters.
Wow.
Because there is shortage at Kenyatta National Hospitals.
Now, before we talk extensively about the graft, let's look at the fistula, the first access that you had gotten, and let's look at the benefits and the considerations of a fistula. Now, the benefits of getting a arterial venous fistula, because we may have people watching this, not just in East Africa, but here in the United States or other places across the world that may be in the same situation, about to get access surgery to start dialysis, or they started dialysis with a catheter. Now their surgeon wants them to get an access. I can hear my feedback in your background, Brother Moses.
Oh, okay. There is someone who, I think there is echo.
Yeah, it's an echo. I'm going to silence you for a moment.
Can it be put off?
No, are you watching it somewhere else? Is someone else is watching?
Just within the room, someone else is watching.
Yeah, tell them to turn it down or go into another space.
Reduce the volume. Reduce just the volume.
Because he's close to you. That's you get the feedback.
Oh yeah. Do you get still the echo?
No.
All right.
So let's talk about the benefits of a fistula, because as I was saying, you may have someone watching in the exact same situation that is about to get access surgery, and they don't know which one should they get, or they don't know the difference between the fistula and a graft. Now, as I mentioned before, a fistula is a vein and artery that are surgically connected. This creates a large, thick vein underneath the skin. Now, once it's ready to use, this vein allows for good blood flow during dialysis and makes repeated needle insertions easier. Now, let's look at the benefits of this type of access, a AV fistula or arterial venous fistula. The benefits is the preferred dialysis access by most nephrologists. And even Medicare here in the United States, they have that initiative, Fistula First. Also, it's the best overall performance with dialysis. And we're like, Steve, what do you mean it's the best? Because it's using your natural veins. It's using your own veins. Okay, and that's why you would get a better overall performance. Lower chance for infection compared to the other access, the graft and and the catheter. And it's long lasting. As I mentioned, I once worked with a lady who had her fistula 37 years. 37 years. The same fistula. Rest her soul, she has passed on, but she was the longest person in Maryland to have the same fistula 37 years. Let's look at let's look at considerations for an AV fistula. May be visible under the skin, takes time to develop, usually 6 to 8 weeks. Requires the use of a temporary access while the fistula is maturing. So while your access is getting ready, you're going to have a catheter in. And you hear a lot of warriors say, I can't wait to get this catheter out and start using my arm. Also, another consideration that a fistula is not suitable. It's not suitable for all patients. You have to remember that, especially if you hear the term small veins. If you hear the doctor say you got small veins, you better ask them what's the other alternative, or ask them to move up to see what size your veins are in your upper arm. Now, let's look at what Brother Moses had. Brother Moses, can you show your arm right quick? Are you able? Okay. I know you're probably still sore.
Are you able to see it?
Yes. Now that bandage can actually come off. I'm not sure how they do it in Kenya, but here in the States, we would have took that off to let the access breathe and to clean it. So just a tip for you. But what Brother Moses have now is a graft. And that's a vein and artery are surgically connected together by a synthetic tube placed under the skin. Okay, so one end is going to connect to the artery and the other to the vein, and it's going to be like a loop. Now, needles are inserted into the synthetic tube rather than the veins. Okay, the needles are going in the tube, not the veins. Now, the benefits of a graft can be easily implanted with a relatively minor outpatient surgical procedure. Like here in the United States, it's in and out surgery. I think Brother Moses stayed in the hospital maybe a day or two after the surgery. And after surgery can usually be used in 2 to 4 weeks. So you can use it more quicker than you can the AV fistula because it's taking your veins time to develop. And sometimes it doesn't, they don't even develop, as in Brother Moses' case. Now let's look at the consideration that Brother Moses had to look at now that he has an AV graft, or any other warrior in East Africa that may have an AV graft. This is the consideration Brother Moses has to look at. Increased potential for clotting. You're like, Steve, why is that? Because now you have a man-made device, synthetic device in your arm, which is a foreign material. And we know blood likes to cling or clot when you introduce foreign material in your body. That's why when you see people getting stents, they're on blood thinners. You may hear of Plavix, Eliquis, warfarin, or Coumadin, or it may put you on a baby aspirin. Also, one thing to consider, higher likelihood of infection compared to a graft. Compared to a fistula. Like, Steve, why is that? Well, again, and I will suggest to Brother Moses, when they start using your arm, Make sure they really cleaning it. In fact, before you go to dialysis, if they don't have a sink for patients to wash their access, make sure you wash your graft with soap and water before you go to dialysis. Or anyone else who has a fistula or graft, wash your arm with antimicrobial soap and warm water, because when you get to the clinic, they may not clean your arm the way they should. They may use one alcohol swab because they may be short of supplies. Or they may use two and just wipe up and down instead of wiping in a circular motion to move the dirt away from the access, from the needle points. That's when you're cleaning the access, you want to start and wipe away from the access in a circular motion. Also, another consideration, not likely, unfortunately, not likely to last as long as a fistula. To be honest, grafts, most grafts have a lifespan of about 5 to 6 years on an average. Some may not last that long, some will. It depends how you take care of your graft. Now, as I will suggest to Brother Moses, to keep his access functioning as long as possible, when they stick you, you want them to rotate the sites. Don't let them go in the same area each time, because now when you stick in that synthetic material, you go in the same area, it can widen. It can widen the hole, and it could take longer for that spot to seal up because you're repeatedly going in the same spot, making it wider. So make sure that 1 to 2 finger widths from the last needle site, like you're doing the ladder, 1 hit a day, and then on the other side, up a little, and just keep rotating. Also, requires the use of a temporary access while the graft is maturing. Now, Brother Moses has his temporary access. He has a catheter. And let me show you how that looks like. This is the catheter that Brother Moses has right now on this right side. Okay? And it's the same concept, right? Same concept as a implantable access, meaning you got blood coming out, the red, and this is a red as indicated by this maroon red port. The blood is coming out, and then you got to have a port where the blood returns. And this is where the blood returns, the blue side, or the venous, as we call it. Also, a graft is not suitable for all patients. It's not. So for most people, they start off in dialysis, they have the graft, and then you go to the unit and they asking you to go make an appointment to get evaluated for access in your arm. And that's where you see patients like, I don't know about that, because they see other patients getting stuck, and some patients may holler, they may see the grimace on their face, and they're like, no, I want to wait for a while. And if that's the case, again, don't let anyone pressure you to go get something done that you're not ready to get done. Because here in the States, they want everybody to get these catheters out, but they know that's not possible, because some patients just have bad vascular veins and they can't have a graft or fistula. So the next best thing is a catheter. So don't let them convince you to do something if you're not ready. Now, these can get infected, and that's why they want you to get it out, because each unit kind of get dinged when they have patients with catheters, because it can put their facility at risk for high rates of infection. And that wouldn't look good with the network if you got a clinic that has a lot of patients with infection. Then next thing you're gonna know, what's going on over there? Oh, most of the patients got catheters. Well, why haven't they had them taken out and have a fistula or graft put in? So yeah. So Brother Moses, I know I talked a lot. Anything?
Well, I also agree with you, Brother Steed, absolutely, that if you don't take care of your access, then you will be in trouble very soon. You know, surprisingly, Steve, I've had my chest catheter for 6 years, since 2017
Wow.
to
You
date.
had your
Just one, never changed.
wait
Just
a
a few
minute.
challenges like infection. So it's really amazing. It is an encouragement to
Wait a
have
minute.
warriors keep their access clean.
Wait a minute, Brother Moses. I'm sorry to interrupt. Repeat that again. You saying that you had your catheter, which I'm
Yes,
holding in my hand, and here in the
yes.
United States, they encourage patients to get this out as quick as possible. Go see the surgeon, and saying you're going to get an infection if you don't get it out. You saying you had this for 6 years.
6 years. So it also takes proper hygiene and understanding how your axes work, right, Brother Steve? So, because, for example, when you go to other clinics elsewhere, they will just sweep the nozzle, or they might not even sweep. So you end up locking your catheter, but then it has not been cleaned. So it is very important for warriors and caregivers to get to learn how these types of access work and how we should take care of them. That is why you see others get longer, others get it to few months, weeks. But then back in our minds, we know that we should get it as soon as possible. But because of financial constraint and other such like related burden, makes patient just live hoping for tomorrow. And that is why personally, I've had mine for 6 years. Never changed, just one. Yes.
Wow. That is absolutely amazing. Ruth Millie made a comment, say, very powerful to hear from Moses that the surgery was successful. Can you hear me, Brother Moses?
I can hear you.
Yes. Yes. So right now, can you feel your access and to see if it's working or not?
Oh, yes. Although it's heavily swollen, you know, the whole arm is swollen. Is that normal? Though I'm
Yes.
due clinic tomorrow. I'm due clinic tomorrow. But
Yes.
is that normal? The
Yes.
swelling?
Swelling is normal. Make sure you elevate your arm on a pillow.
On a pillow.
Like if you're sitting, if you can get something where you can elevate your arm, it will help decrease the swelling.
Okay. but it has the thrill. I can feel.
Yeah, you can feel it.
I can feel the thrill. I tried it that way. I thought you would hear it from that end.
Do that again. Oh, you put the earphone up to it.
Yes.
Try that one more time. wasn't
Okay.
really paying attention. I really can't hear it that well, but can you feel it?
I can feel it.
Good. Now, we had a question from P Teach from YouTube. She said, hello, Steve and Brother Moses. How long can one wait to get the catheter once notified? Now, Brother Moses, this is different for each person. And by you being in Kenya, when you found out you were sick and had to get dialysis, when did they put your catheter in?
Well, in Kenya, it varies. Number one, it depends with the hospital where you are, and then how swiftly you've got the right doctor. Sometimes people tend to go to primary doctors, then they get delayed for them to notice that one is suffering from end stage or someone is crashing to dialysis, just the way I did. Now, in that case, it might delay because maybe you need travels to other cities where nephrologists are who can fix the catheter. So it basically depends. It depends with an individual. But assuming that all factors are in play, it can take even minutes, Brother Steve, because once you are diagnosed, you have kidney failure, and you are due dialysis, they'll just fix it, even without your consent, just to save you.
Wow. Well, yeah. Teach, let me tell you how it normally done here. So here in the States, if a person, say, goes to the hospital because they don't feel well, and the doctor comes in and say, your kidneys are failing, we need to start dialysis. Normally what they would do is put the catheter in that day. They would consult with vascular, and it may be today, it may be tomorrow. But if you need emergency dialysis, they're going to put what's called the IJ, which is a temporary catheter on the side of your neck because it's easy to put in, and right here in your jugular vein, and we can start dialysis like right away. They can put this in at the bedside. Right there at the bedside, they numb you up, come in and put it in. And then once they get you situated, then they make schedule to get the subclavian catheter put in. And then once you got that in and they got the dialysis managed, now, depending on when you're ready to leave the hospital, now they're finding you a place to go. And once you get to that place, meet the doctor, whatever the case may be, they're going to start trying to set you up to see a surgeon to get vein mapping and schedule that surgery. And that's when you can say, no, I'm not ready. Or it could happen this way. You could be seeing a kidney doctor and he could be following you, and you could be at stage 4. And then the doctor could come to you and say, I think we should be thinking about getting the access put in now, even though you're not on dialysis. So if when the time comes, if you got to start, you'll have the access already in, and you just go to the clinic. Now, I've seen that many times where a person start dialysis and they already had the access in, and they bypass the hospital and they come straight to the clinic and start their treatment. A lot of times when a person gets very sick or something else happened that lands them in the hospital and they find out with dialysis, they put the catheter in. So it just depends on the situation, Pete Teach. If you're seeing your nephrologist and they're following you, they may say, hey, let's get a access put in. So when you start dialysis, the access will be ready to use. So, Brother Moses, have your doctor talked about any complications or what you should do or not to do while this access is healing?
Not much, I guess, but I'm going to clinic tomorrow, and I will be asking as much as possible questions that will answer all what I want to know. What I know is that it is still working, and I do not know much about it still. And Brother Steve, just asking, do you need to exercise the graft? Just like the feet?
No, Brother Moses, because
Okay.
you're not building the veins up like you would a fistula. That's why they do the ball exercises or have patients squeezing something to increase the veins. But Brother Moses and other people watching, let's look at some tips to care for your access that maybe your surgeon may not have mentioned to you, Brother Moses. Again, guys, this is Kidney Hub East Africa. Your host, Steve, the kidney nurse, and host, Brother Moses Kennedy, also known as the Kidney Ambassador. And we're talking about dialysis access surgery. And we're live from Nairobi, Kenya with Brother Moses. So let's look at some tips to care for your access. And this goes for anybody watching or just got recent access surgery. Keep your access clean. And I mentioned that to Brother Moses. If you have an AV fistula or graft, wash it with soap and water every day. Not just when you go to dialysis, but every day, especially just prior to a dialysis treatment. Because again, the technicians or nurse may not clean your arm the way you may clean it. And we got germs on you can't see the germs, but when they do the wipe with the alcohol pad, you see how the dirt comes off. Or if you use lotion or any type of moisturizer cream, you want to get that stuff off your access. So when you penetrate your access with the needle, you don't want the germs going under your skin into your bloodstream. If you got a graft, that's a man-made material. You don't want any germs to get on that. Minimize risk of infection. That's another tip. Avoid scratching, coughing, or sneezing on your access. Avoid pressure on your access by one, not wearing clothing with tight armbands or jewelry around your access area. Now, Brother Moses, it looks like his access is up here. So with him, what he may want to consider not wearing long sleeve shirt to dialysis where he's going to have to roll his shirt up, and it may squeeze or compress where the access is, possibly causing higher pressure readings than normal, because now you got a compression. You got that sleeve compressing down. So I recommend, Brother Moses, if you got to wear a long sleeve shirt, to take it off and have a undershirt under you like you have on now, where staff can get access to your arm. Also, do not carry heavy objects with your access arm. You want to be careful with that. And another thing you want to be careful with, don't let anyone but your dialysis or vascular care team touch your access. Your access arm should not be used to check blood pressure, draw blood, or place an intravenous line. So say if Brother Moses goes to the hospital for something totally different, and they like, we got to draw blood. We can't find your veins in the right arm. Then even like, hey, Mr. Kennedy, can we use the other arm to draw blood? No, you got to find somewhere else. Even when you go and they want to take your blood pressure, don't let them put that cuff on that access arm. In fact, some places have something like a sleeve that they put on that says do not touch access. When they go to the hospital, go anywhere, like one of them sweatbands that come from your wrist to your elbow. And so you just want to make sure that staff that doesn't work in dialysis or the access touch your arm to try to draw blood. Brother Moses, any comments so far?
Well, I know how sometimes staff could be in a position to do the right job at the right time, but then sometimes they tend to just avoid it, to do it in a shortcut manner. So if you as a caregiver or a patient, I mean a warrior, then you must be very careful. You must take that proactive action to ensure that it is properly cleaned, soap and water. Then later on, do not just let them run the swab once. Raise your voice and ensure that it is done properly. And even you could be saving the next patient next to you, Brother Steve.
Oh, okay. Good tip, Brother Moses. Hey, Miss Elizabeth Ona. Brother Moses, we have a question. Hello, Steve and Brother Moses. Does the vascular surgeon install the catheter?
Oh, yes. A vascular surgeon normally goes with they are called thoracic and vascular surgeon, and they deal with the veins, the vessels, and the heart. In simple terms. So yes, they are well placed, quite much well placed to do the catheter.
Correct.
I guess that, Brother Steve, but I stand to be corrected.
Yeah. Here in the United States, yes, a vascular surgeon or one can go to the access center where most of the time it's an interventional radiologist. They can put in catheters. Even a nephrologist, a kidney doctor that's trained in interventional radiology can put in a catheter. Also, Miss Oldham asked Steve, does it matter which arm is used to draw blood for taking blood pressures before surgery? No. If you haven't had that surgery, the access surgery, it doesn't matter where you draw blood, what arm you draw blood or take the blood pressure. It's just once you get that access placed in your arm, that's when you don't want that to occur. Also, let's look at, as we're almost out of time, but we're going to go over a little bit because this is an important topic. Let's look at what kind of access problems can happen, because access problems do happen. Make no mistakes. And this is why, this is why checking your access is very, very important every day. So the most common problem is low blood flow due to narrowing or blood clotting in the access. That's the most common problem. Narrowing, also known as stenosis, can lead to clot formation, which will reduce the overall effectiveness of your dialysis treatments. And eventually, blood flow through the access may stop. Now, let's look at the kind of tests and procedures one may need, such as Brother Moses. If one is having problems with their access, the nephrologist may decide to refer you to a vascular specialist for evaluation. Now, the vascular specialist will determine if you need an interventional procedure to ensure you leave with a fully functioning access. Now, here are some of the tests. Physical examination of your access helps determine if further testing is needed. A fistulogram, the diagnostic test of choice to aid physicians in determining the cause of access malfunction and how to correct them. Angioplasty, a catheter-based procedure to widen a narrow fistula or graft to correct it, to it full function. Thrombectomy or declot is removing clots from an access to restore blood flow. And then stent placement, a small wire mesh tube matched to the size of your AV fistula or graft is permanently placed to help hold it open, allowing for blood flow. That's what the stent does. Now, what happens if your access stops working? If the thrill in your access is absent, you should call the dialysis team immediately. In this case, Brother Moses is going to call his surgeon. Your access is clotted, and a procedure known as a thrombectomy needs to be performed to declot, to remove the clot from the access. All right, Brother Moses, anything you want to say before I get to this last part?
Well, I know sometimes there are several challenges the consequences of using each access, but the whole thing is about the buck stops with us. We need to have to be proactive, because at the end of the day, it is your body, Steve, that you are taking care of. So very importantly, we must just keep on understanding our conditions.
Absolutely. Absolutely. I agree with you, Brother Moses. I definitely agree with you. So, as we come down to the home stretch, dialysis will be most successful if your access is functioning well. Early detection and timely treatment of dialysis access dysfunction are critical to the preservation of your access. Now, let's look at some common signs of access dysfunction before we close out. Redness or swelling may be signs of infection. Redness or swelling may be signs of infection. Brother Moses, in your case, the swelling is due to recent status post-surgery. The absence of or a change in the pulse, which is the thrill of your AV graft or AV fistula. This is a common sign of access dysfunction, the absence of or a change in the pulse, the thrill of your AV graft or AV fistula. Swelling in the access arm and or your hand is numb, weak, and feels cold. A lot of warriors experience that after access surgery. Numbness or feel cold in your fingertips. Another common sign of access dysfunction, prolonged bleeding post-dialysis. Prolonged bleeding post-dialysis. An AV fistula failing to develop. In this case, Brother Moses had that happen with his first surgery. The AV fistula failed to develop. Another one, elevated arterial and or venous pressures while receiving hemodialysis. And you look at the machine, you try to find what the baseline of your arterial and venous pressure is. It may be arterial pressure, your baseline may be negative 190 or negative 200. And the next thing you know, when it goes up, like negative 280, negative 300, that means there's something wrong with the flow. Same with the venous pressure. If you got a high venous pressure, you need to check the needle placement to see if the needle is against the wall, causing the pressure to go up, or if it's in the access. Also, difficult sticking of your AV fistula or graft. If the staff is having difficulty putting the needles in, you may want to get that checked out. Or it could be the staff. Now, what happens if my access is no longer functioning well? Sometimes, even when you take the very best care of your access, you may experience problems. An interventional procedure to correct the problem and improve the function of your access might be required. Now, this is from one of the access centers here in the area. Now, Kenya and East Africa probably don't have independent or standalone access care centers where they just work on the access. You got to go to the hospital. In this case, people avoid going to the hospital and go to the access center to get the outpatient procedure done and come on back home. So with that being said, this has been really an informative show. And let me just say this. Overall, access surgery for dialysis is crucial for patients with kidney failure, as it provides a way to safely and effectively remove and return blood during dialysis treatment. Brother Moses, you have any last words or comments?
Oh, yes.
The
There is something you talked about, and it stands out. This is a standalone access centers. I think it is really a good idea over there in US, and it has to be recommended. But in our case in Kenya, you have to visit hospitals and go through the tedious means or tedious ways and means of getting admitted and, you know, getting the procedure done. So that is really great.
Yes. Maybe you can possibly ask your surgeon. I mean, see what he says about that idea. But yes, man, we need some changes so warriors over there can have better management and access to vascular surgeon to make sure that they're getting the proper access done and not getting unnecessary surgeries, especially when it comes to vein mapping. That should be included, I believe, in with insurance reimbursement over there.
I get you.
So any last words, Brother Moses, before we end the show? Anything you would like to say to the audience?
Oh yes. Access are our dialysis access are our lifeline, and no matter what comes, it is first you need to take care of it. Getting care of it in a manner that you really understands how it works, how it should be maintained, and how, again, you can notice some dangers, some green lights on keeping up with access. So yes, Brother Steve, education stands above all. Knowing your access, learning it. That is all.
I agree with you 100%, Brother Moses, and I'll definitely wish you a speedy recovery, and pray that everything works well with your arm when it's time to cannulate it, and that you get a long use of that access, and that also you're able to get a better treatment, quality treatment, because we know, again, using catheter, you can have some great outcomes too, as well as having fistula or graft. But using the implantable, the graft or fistula, one has good outcomes better than catheter, but it depends. So I've seen some people with catheters run at 400 blood flow rate and have some great outcomes. So it just depends on the person. It just depends. So wishing you a speedy recovery. And again, thank you for taking the time to come on the show today. I know you're tired and you've been through a lot the past week. So you showing up is greatly appreciated, and your dedication.
Thank you. Thank you, Brother Steve.
All right, guys. So this is it for this broadcast of Kidney Hub East Africa. I am your host, Steve Belcher, and Brother Moses Kennedy, live from Nairobi. And we'll see you hopefully again next Sunday, same time, same channel. Brother Moses, again, thank you for coming on, and we'll talk soon, okay?
All right, we'll talk soon.
All right, take care, brother.
Have a good day.
All right, you too. Everybody, have a great day and great night. God bless.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.